Good morning. It's really nice to be with you all. I'm Laura Makaroff. I serve as Senior Vice President for Cancer Prevention and Survivorship at the American Cancer Society, and I also have the honor of being the ACS Chair for the NCCRT. I've been involved with the NCCRT a long time now, and actually was part of how I got introduced to the American Cancer Society back in my former role a long time ago now. So it's really great to be here and have this time together. So I'm really excited about our panel today. This is our panel on timely colonoscopy follow-up for positive or abnormal non-colonoscopy tests. We have a great panel here. Like Steve just walked us through this the strategic priority, the roadmap. Take a look at all the posters out there. We really are interested in your feedback and ideas on things we can do together as a roundtable, things your individual organizations can do to advance our shared agenda to make a big difference in colorectal cancer. So this session today will provide some updates on our work towards an evidence-based colorectal cancer screening follow-up quality measure and showcase some examples of pioneering efforts to track and improve timely follow-up rates. Before I turn it over to our panelists, I just wanted to set the stage for our discussion. I think this will just be like kind of set the stage so we're all thinking about this issue. You know, as we know that this issue of completing the screening process and timely colonoscopy after a stool-based test or other non-colonoscopy test is really important and continues to be a big challenge for us. We know that 20 to 40% of patients with an abnormal FIT DNA, or other non-colonoscopy screening test don't complete a colonoscopy following that within the guideline recommended timeframes. Really troubling. And additionally troubling is that some percentage of people never complete follow-up at all. So we're going to talk today about how we can ensure that every individual completes the full screening process and just remember why this is a top priority for the roundtable. We know that if people don't follow up and finish their colonoscopy and complete the screening process within 6 months or even longer, we know that outcomes are worsened, and we have a chance today to learn about how to really work towards solving this complex multifactorial problem. It's not just patient adherence or colonoscopy capacity, and we don't mean to simplify this really complex issue, but we'll hear today about the work that's happening nationally about a HEDIS measure, and we'll also hear about some health system best practices and lessons learned about what works to really improve this issue. So let me introduce our panelists, and so we can dig in and dive into the panel. Our panelists will each share and have a presentation, then we'll have some time together for Q&A. So I hope you'll save your questions. We'll have some robust discussion together at the end. So our panelists today, first we have Dr. David Lieberman. He's Professor Emeritus at the Department of Medicine, Oregon Health and Science University. He will share today about our work nationally toward a HEDIS measure. Then we have Dr. Frank Colangelo, who's the Vice President and Chief Quality Officer at Premier Medical Associates Allegheny Health Network, and is the Priority Team Co-Chair for our Professional Education and Practice Implementation Group here with the NCCRT. He will share about what the work that he's been doing and then work through an AMGA collaborative on this issue. And last but certainly not least, we have Dr. Miranda Hart, who's Senior Medical Director, Integrated Primary Behavioral and Population Health at Erie Family Health Centers, and also, as we just heard, our 2025 National Achievement Award honoree at Erie Family Health Centers. So welcome. So I'll turn it over to Dr. Lieberman, and then we'll hear our presentations and have some discussion.
Thank you, Laura. It's really a privilege to be here with you, and I've always enjoyed this meeting a lot. This is a topic that is near and dear to me, and so I'm going to I'll provide a little bit of background, and then I'm going to talk about a new HEDIS measure that is being developed right now. So the colon cancer continuum, these are my disclosures. First, I want to make a comment about a non-invasive screening program. It can work. And we have great evidence from this study that was from Kaiser back around 2000, in the early 2000s. They realized that only 40% of their age-eligible cohort were actually getting screened. So they said, we have to do something about this. And so they instituted a program of mailed FIT kits. They would mail the kit on the individual's birthday, so it would be a nice birthday present arriving for them. And they did more than that. If the kit didn't come back, they followed up with contact with those individuals to try to ensure that they could get as many kits back as possible. And then, if the kit came back and if the test was positive, they helped navigate the patient to getting a colonoscopy. So what you see on this slide here is what one of the primary goals that the NCCRT has had, which is to achieve an 80% screening rate. They actually got up to 82% overall. But also important here is that the completion of colonoscopy for positive FIT tests was 80%. So it shows that it can work. And when it does work, here's what happened. Mortality dropped. And Steve already talked about this, that if we reduce incidence, we're going to reduce mortality. And indeed, that's exactly what happened. In a later nested case control study that they presented, they demonstrated that exposure to FIT during, in this organization resulted in a significant reduction in colon cancer deaths. So a very important study, I think, demonstrates that the efforts that everybody in this room is making to try to ensure that people get screened, it does work if we do it well. Okay, but I call this the Achilles heel of non-invasive colon cancer screening. There are two important key elements here that I think where there are some gaps. So one is the time we follow up of abnormal tests, which is the topic of this, what we're talking about today, and then repeating tests at appropriate intervals if the test is negative. So in a busy primary care practice, we offer the test to a patient, and we know that if that test isn't completed, the program is not going to be successful. So the test completion rate nationally is somewhere between 60 and 80% when it's offered. If the test is positive, we know we have identified an individual who has a higher risk of colon cancer. Those individuals should be referred for colonoscopy. And the actual completion rate of colonoscopy is less than 50%, and I'll show you some data on that in just a moment. And then if the test is negative, we know that these tests are not perfect, and they should be repeated at an appropriate interval. And the repeat rate, primarily with FIT, is somewhere between 20 and 65% based on the literature. So we're not doing as well as we could, and that's why I refer to this as the Achilles heel. I want to come to this completion of colonoscopy because I think this is one of the most important elements. We're doing a non-invasive test to identify a patient that has a higher risk of cancer and should get a colonoscopy. This study from Italy, I think, is very informative. So this is over 100,000 patients that had a positive FIT test. 23,000 did not get a colonoscopy. They refused to have a colonoscopy. 88,000 ended up getting a colonoscopy. And then they followed those individuals over the next 10 years. And what you see here is very dramatic, that this is about mortality after a positive FIT test. The individuals that did not have a colonoscopy after a positive FIT test had a twofold higher risk of dying from colon cancer compared to those that got colonoscopy. So I think this is a pretty important study and highlights why this is such an important subject. So how are we doing? Well, the adherence to completing colonoscopy in a timely fashion is variable. There's national claims data. In safety net settings, it's as low as 18%. The VA does reasonably well at 62%, and there are some integrated healthcare systems, as I showed you, that hit 81%. On this slide, I showed data from 39 different healthcare organizations where the completion rate at 6 months is about 51%, and at 1 year, 56%. So you can see that there's quite a bit of variation, but it hovers around the 50% range for patients that have had a positive stool test. But in addition to stool-based tests, we now have blood tests. And so there's some new data that was just published this past month about what happens after an individual has a blood test and then that's abnormal, how often are they getting to colonoscopy? And you'll see it's very, very similar. This is a small study, but I think it demonstrates that we're achieving about a 50% rate of getting patients from a positive test to a colonoscopy. And I think most of us in this room would agree that that's less than satisfactory. So, why is this happening? And I think there are probably many reasons. These are reasons that have been identified in the literature. So one is just education, understanding the importance of a positive non-invasive test. I think when in a busy primary care setting where a patient is handed a fit card or mailed a fit kit, that education may not be adequate. The bowel prep. We hear from patients that the bowel prep is an important barrier. So figuring out ways to present the bowel prep and take away some of the mythology that people hear about bowel preps is very important. I'm a huge believer in humor in presenting patients with explanations of bowel preps. And when I'm with patients, I describe my personal experience with bowel preps. So it helps. Copays. So when the Affordable Care Act was initially passed, CMS interpreted this as suggesting that screening tests would be performed without a copay. But by their definition, a screening test, a non-invasive screening test, was the test. And then if the patient had a positive test and needed a colonoscopy, that was called a diagnostic colonoscopy and was not covered under this, and there would be a surprise bill for patients. We spent about 10 years lobbying CMS. Many in this room participated in that effort, and finally in 2023, they agreed that the screening continuum for non-invasive tests includes a colonoscopy if that test is positive. So that's now been eliminated as a potential barrier. Transportation, you're going to be hearing more about transportation here at this meeting, can be a barrier for individuals, and having somebody that comes with them to make sure that they get home safely after a colonoscopy is really important. So there have been some nice studies done, and I think we have Ari from Seattle that's going to talk a little about the experience there with using rideshare services that has been very successful. Missing work is an issue for many individuals. If you miss work, you miss a paycheck for some individuals. So that can be a barrier. Childcare, elder care. Some people have responsibilities outside of their regular life to take care of children or aging parents, and that can be a barrier. Missing a day of that can be a problem for some individuals. And then scheduling issues. So colonoscopy requires getting scheduled into an endoscopy unit, and if that schedule is packed up and filled, then it's going to be very difficult sometimes to get patients in a timely fashion. So I have coined this idea of having a TSA approach to scheduling patients for colonoscopy, and my TSA definition is a time-sensitive appointment. And that means getting that patient in within 6 months if we possibly can, because that's when we start to see some change in the risk of having a more advanced lesion in the colon. So that's another issue we need to work on. The solution for some of these problems has been shown to be navigation. So navigation can be very effective for helping patients complete tests that are not completed, assuring that patients get scheduled for a colonoscopy, and then helping overcome some of the other barriers such as transportation, geography, missing work, family care, and trust issues. So I think a navigation, selective use of navigation can be very, very helpful. But there's a barrier to navigation. There's a cost. And so who's going to perform navigation? Well, it doesn't have to necessarily be a healthcare professional. I mean, it's traditionally done by nurses and medical assistants, but it could also be done by peer counselors, which might reduce some of the cost. in many settings, and I know there are people here in this room that are experts in navigation. They can be multitasking, so they could be working with patients on colon cancer screening, but also other health issues, management of diabetes, management of hypertension, and other things. So I think there are ways to utilize navigators to help with many healthcare issues. And the important message, I think, to healthcare organizations is that there are some tremendous downstream benefits to improved adherence, including the reduction in colon cancer incidence and mortality and reduced long-term healthcare costs downstream. So convincing organizations to do that and invest in that, I think, is important, and that's something that we're working on. So I mentioned that there is work being done right now to develop a new HEDIS benchmark. So right now, for colon cancer screening, the benchmark is that you offer the patient a screening test. And you can check that box, and that satisfies the requirements. But as I have said, that isn't going to be helpful for the patient in reducing incidence and mortality unless the patients with positive tests get to a colonoscopy. So that has now gotten the attention of people nationally, and so there's efforts now to develop a HEDIS requirement. So I want to spend just a second talking about how these measures get developed, the sausage making that goes into the development of a measure like this. So here are some of the questions that we have been wrestling with as the measure is being developed. So first of all, the premise is that non-invasive screening tests are used to identify higher risk individuals who should have colonoscopy. Those individuals should get a colonoscopy. So should the measure apply only to stool tests, or should it apply to all non-invasive tests? So that's one of the questions that we have been wrestling with. I think there's consensus that it should apply to all non-invasive tests. If we're using the non-invasive test to identify a high-risk patient that should get a colonoscopy, then it's reasonable to make that part of the requirement. Second is timing. So what is the appropriate maximal time interval between a positive test to a colonoscopy? As Steve mentioned, the clock starts ticking with that positive test, and the evidence is that somewhere in that 6 to 9 month period after the positive test, we begin to see that the risk of a more advanced lesion increases. So developing that and finding an appropriate time interval is important. What's the appropriate benchmark for performance? 100% is not going to be feasible in most circumstances. So in trying to develop a benchmark that's acceptable to providers, we need to come up with an appropriate benchmark. So there's going to be some field testing that's going to be done to help determine where that benchmark should be. Are there some special considerations? We know that some patients get a non-invasive test who probably shouldn't be getting a non-invasive test because they have too much comorbidity, frailty. They're unlikely to benefit from screening because of comorbidities. And so that's going to have to be taken into account. And somehow that has to be measurable. And so, there are comorbidity indices that can be determined, and that could be part of the measure. But the reason I'm pointing this out is to illustrate how complicated this measure can be. Feasibility. Can the data actually be extracted? So if you're going to create a measure, you have to have a way to measure it, right? And so you need to be able to find out, at least have the information about the date of a positive non-invasive test, and then the date of the colonoscopy if it's completed. So that information should be available in an electronic record of some kind, but that's not always true. And then finally, a question that we've had quite a bit of discussion about is, should there be a requirement for adequate colonoscopy completion? So We've had, in previous years, there's been some discussion here about the quality of colonoscopy. If the colonoscopy is performed, but it's not a high-quality colonoscopy, does that meet the measure? And that's an important question to consider. So these are just some of the things that are being considered right now, and I don't have answers yet to all of these questions. Some of these questions will be addressed and answered during some field testing. Here's the proposed timeline, and I was given permission to show this slide here today. So the concept dates back to the beginning of this year. There's been some convening of experts, and I had the privilege of being one of those experts to help draft some of the specifications. There's a larger advisory panel, and then there's field testing that's planned for actually right now. There'll be a period of public comment in early 2026, and an ultimate vote on a measure by this advisory panel. It will get published, it will get implemented, and that's not the end of the process. What they do after that is that they will analyze data from year one, and it becomes an iterative process, so they may come back and revise it at that point. So that's the hoped for timeline. So you can see that implementation, the best case scenario would be in 2027. So in summary, non-invasive colon cancer screening programs can work, but they depend on completion of the screening test and the appropriate follow-up of both positive and negative tests. The failure to complete timely colonoscopy after positive tests is a very important gap in the screening continuum. Evidence-based methods to improve the follow-up of positive non-invasive tests include navigation and HEDIS incentives. I'll close with one of my favorite photos of the Oregon coast. This is the sun setting on the Oregon coast, which, by the way, if you've never been there, is a beautiful place to visit. And I want to leave you with the message that colon cancer screening is effective if it's performed with high quality. Thank you.
Thank you so much, Dr. Lieberman, and maybe we can do our next meeting in Oregon. Looks like it'd be nice to go there. Let me turn it over to Dr. Colangelo for our next talk.
Thank you, David. Thank you, Laura. I'm Frank Colangelo, primary care doctor in Pittsburgh. I am giving this presentation on behalf of AMGA, the American Medical Group Association. I'm on their foundation board of directors. I was one of their advisors for this campaign that just completed. And Dr. John Kennedy and Dr. Elizabeth Siemens, who presented on this in the last two meetings, weren't able to attend today, so they asked me if I could present the results of the collaborative that ended. So it's hard work. They asked me to talk about the follow-up measure after an abnormal stool-based test. I wanted to first highlight some of the other successes of the campaign before I go into that. So AMGA, the American Medical Group Association, a trade organization representing the interest of health systems and physician practices, but they have a foundation which runs quality improvement projects. They've done multiple over the year, the most recent with this colorectal cancer collaborative, and they have a research arm who publishes. And I went to them about 5 years ago and said, we need to do something organized across the organization for colorectal cancer screening and follow-up after testing. So we worked in collaboration with the roundtable, and Emily Bell was key with helping us with organize the program, and had a number of advisors that were part of the campaign. Many we see here in the room, Andy and myself and TR and Laura helped, and Pascal and Dorado were advisors for the campaign that helped the organizations. And whenever they were setting this up, I was the one who said, we have to look at the follow-up after positive stool-based test or abnormal stool-based test. And applications went out in early 2023, and about 34 organizations submitted applications to become part of this collaborative. And one of the questions is, does your organization know what your screening rate is, and do you know what your follow-up rates for abnormal colonoscopy after abnormal testing? And at that time, 2 of the 34 organizations were able to say, yes, they knew it. Now they all say, we will figure it out right now. So, but, it's, just two and a half years ago, people weren't following this. They weren't figuring it out. So if there was one thing that happened, we allowed a number of organizations from across the United States who became the 20 that were part of this collaborative, ranged in size from 100 primary care providers to 7,000 primary care providers, and geographically dispersed across the United States, were part of this effort. And we started onboarding from May to August of 2023, which individuals had to come up with their baseline data and develop quality improvement teams that would help the effort. Between September of 23 and February of this year was the active implementation of the program. There were 2 in-person meetings that occurred, regular webinars, virtual engagement activities. It had to submit quality improvement and submit results on a quarterly basis, and had a final virtual visit. And now the AMGA team is right now in the process of doing final analysis, synthesizing the results and preparing publications from the effort that occurred. And organized activities that AMGA's quality improvement team helped the groups that were involved. Clinical outreach and coaching, quality improvement techniques were taught, measurements, benchmarking for the program, the organized webinars with experts, the virtual and in-person engagement activities, and they provided us with resources that we could share across all the groups to help with the effort. And, we looked at the number of patients who were up to date with screening between the ages of 45 and 75. They had to stratify them for both socioeconomic, race, ethnicity, and insurance coverage so that we could track and address disparities. And then the other important thing was what % of patients who had an abnormal stool-based test had a follow-up colonoscopy done within a timely basis. And AMGA said they developed a population health model, the up-to-date screening, achieving equity, follow-up after, and using shared decision-making to help our patients with this journey. Now, there were 20 organizations that reported over the period of time. There were 4 million active patients across the 20 organizations between the ages of 45 and 75. And similar to the rest of the country, even after 18 months, about 68.2% of patients were current with screening at the end of the last data period. There were almost 1.7 million screenings that occurred during that 18-month period of time. 1.3 million additional patients received screening during that period. Some were already up to date and were just doing repeat screening. And many of the organizations went above the Healthy People 2030 goal of 68%. And I have a slide that shows everyone did a great job in terms of closing the gap for the 45 to 49 age group versus the rest of their panel of patients that they took care of. And they estimated about 130,000 extra patients were screened for colon cancer, patients who had never been screened before as a result of the campaign. And the age-based disparity, there was great improvement, almost 8% absolute improvement in the 45 to 49 age group over the 18 months. And they reduced that disparity between that and the highest rate, the Medicare patients, by almost 9.4 percentage points over the period of time. And for commercially insured Medicare patients and Medicaid and uninsured patients, there was an improvement in the overall screening rates for those patients. So a lot of good stuff happened as a result of the AMGA collaborative. But I think David took some information from this paper that was present that Elizabeth presented a couple of years ago. It was only about 51% of the patients did their follow-up within 6 months of that abnormal test. Significantly fewer Black or Asian race had their screening done, or the completion of testing done, compared to white patients. Medicare and Medicaid patients, less completion compared to commercially insured patients. There's about an 18% difference between patients who had a multi-targeted stool DNA test and a FIT test. The multi-targeted stool DNA test had a higher completion rate within 6 months. And the patients with higher Charleston comorbidity scores, as you mentioned, those patients were less likely to have the follow-up completed too. Part of this study too, it wasn't just quantitative. We looked across 39 organizations, but we did qualitative interviews at about 10 different organizations. They said that every single primary care provider leader, what % of your patients with an abnormal stool-based test has a timely colonoscopy? And every one of them said, oh, 100%. And then we showed them the data and they said, oh no. So it was interesting. People just don't know. People aren't measuring it and they're not aware of the problem. So, and whenever the collaborative, it was 18 months, we were reporting on a quarterly basis. So we were aggressive. We decided to report on the 90-day completion rate because whenever we looked at the number, about 80% of the colonoscopies that were going to be done within 6 months were done within 90 days. So for reporting and because of the quick period of time of the collaborative, we decided to report on the completion of colonoscopy within 90 days after the abnormal test. So there were 1.2 million stool-based tests, 55,000 patients across the 20 organizations had an abnormal, and 25,700 had a colonoscopy within 90 days of the result. So around 50%. So we're having trouble moving the number in spite of people working hard on this. Now, TR suggested we need to shoot for 80%. These patients are high-risk patients. We have to get to 80%. Well, that would mean 72% within 90 days because of, that would reflect 80% within 6 months. So 2 of the organizations improved their baseline gap by 30%, and about half the organizations had a 7% improvement from their baseline year through the past year. And, it's variable. I mean, some moved, some didn't move, but it was about 6.7% relative increase in terms of the follow-up rate in spite of all of the efforts. So this is hard. I mean, these were great organizations with huge quality improvement teams and were focused on getting this done in a period of time. And we were disappointed it didn't help as much as we thought it was going to help in spite of all the work that was put into this. Now, some of the organizations who were successful, we asked them, what do you think? The ones that had better results, the ones that improved 7% or more. And these were all the things that people threw out, but I highlighted the ones that they emphasized the most, saying we need to empower GI to help track patient outreach along with the primary care, have to research how many colonoscopy follow-up slots we have, make sure we have access, have a closed loop referral process, have to have some way of denoting high priority on the order. And some said when GI is notified at the same time as primary care that this helps, and they emphasize we're going to make sure we contact the patient within 5 days and try to schedule within 4 to 6 weeks. Those were the more successful organizations. And then as far as access goes, this is my last slide, an AMGA looked at it, so across 20 organizations, if we wanted to get from where they ended up in the mid-50s to the 72% goal within 90 days, across 20 organizations, that would have been 2,020 additional colonoscopies. So it's not like it's 50,000 or 100,000. It's not a big number. And they suggest that if we could just take some of the routine screening colonoscopies we're performing and maybe shift to stool-based testing for those patients, we could open up capacity to get these patients that are at high risk, their colonoscopies completed within a timely period. So it's just a real world look at the effort that we're done to do this. Some improvement made, maybe not as exciting or as successful as we had hoped for, but a lot of extra patients were screened and hopefully benefited from the results of the effort. So, thank you.
Thanks so much, Frank. And next we have Dr. Miranda Hart with Erie Family Health Centers.
Thank you so much, and I feel like this was a great introduction for what I'm going to tell you about. So my name is Dr. Miranda Hart. I work at Erie Family Health Centers in Chicago. I did want to note that we did receive a small grant from Exact Sciences in order to support our colorectal cancer screening efforts. I have no personal disclosures. First, before I talk about timeliness to follow up to colon cancer screening, I wanted to make sure to let you know a little bit about our organization and the work that we do. So Erie is a federally qualified health center in Chicago. Our mission is to provide high-quality, affordable health care to all patients and to support healthier communities. These are some of our values: social justice, impact, excellence, relationships and learning. And access for all is a huge part of what we do. So we have 13 locations across the city and suburbs in the Chicagoland area. And we provide care for over 95,000 patients. And we are a health center that's really takes pride in the quality of care that we provide. So we're in the top 10% of community health centers nationally and #1 for quality in Illinois. The one thing I wanted to highlight for you is our patient population is very diverse and at high risk of having significant delays in follow-up for colonoscopy after a positive fecal testing. About half of our patients don't speak English. 22% of our patients have no insurance at all. And this significantly, and you can see 90% of our patients have incomes under 200% of the federal poverty line. So in order to help support our providers in the population health outcomes that we're looking for, we do have a dedicated population health team. And we have found that in order to be able to provide the best support for the highest number of patients, we really need to tier our support. And our tiering for support for patients actually tracks along with our career ladder for our population health team members. So the new team members who are just joining our organization do routine support for all of our average risk patients, things like ordering colorectal cancer fecal testing, sending text messages to patients to remind them to return their tests. And then once we have patients who we know that they're a higher risk for a particular condition, in this case colon cancer, we do have a higher trained team that does personal navigation for them. The first thing that we identified was really important for our patients was to make sure that we were closing the loop on open referrals. So we actually have monthly reporting on all of our open colon cancer screening referrals that looks at all of the orders that have been placed by providers for whatever reason, whether it was placed for a positive fecal test or because a patient is higher risk for another reason. And then our team actually looks through our electronic health record, both for scan documents that have already come to our health center, but also through interoperability, looking at records from external health systems to make sure that we know which of those cancer screening tests have been completed. And then if they find that the referral is indeed still open, they can then focus on reaching out to patients who are having difficulty navigating the system on their own. These are some of the things that we have found to be the most challenging for our patients. I think they echo a lot of what Dr. Lieberman already discussed. For our patients in particular, with the language barrier and also literacy barriers, actually understanding what a referral is and how to schedule an appointment is a huge barrier. And navigating complex phone trees at hospitals, we know it's gone are the days where you call and a person who works with the provider answers the phone. So navigating those complex phone trees can be really challenging. Transportation is a significant issue. Most of our patients do not have their own transportation. And this need for an escort is actually huge for our patients because many of them, it's not just themselves taking a day off of work, but the other person who's the second income generator in their household who needs to take a day off work to be chaperoning them on their way home from the procedure. And child care and elder care is an issue for our patients as well. So one of the things that we found was most important from a provider standpoint to develop buy-in for this and trust that our population health team was doing this work is actually documenting it in our electronic health system. So you can see here that we have a dedicated area within our electronic health record where we can see as a provider, so I see my patient had a positive fecal test, and the navigators have been reaching out, helping them understand what the referral is, how to schedule that appointment, and then addressing any other barriers. This has been huge to help us understand and also eliminate duplicate work and really focus on how we can best serve these patients. One of our biggest challenges as a health system is working with hospital partners. So we're a federally qualified health center, strictly outpatient practice, all primary care. And as I mentioned earlier, about 22% of our patients have no insurance at all. And the vast majority of our other patients have Medicaid as a payer, which is not the ideal payer for our hospital systems. So we really had to go to our hospital partners and say, look, we are doing the vast majority of our screening through fecal testing. We are only sending you the patients who really need a colonoscopy. And please, what can you do for us to get them in a timely manner? So we were able to develop expedited referral pathways for patients with positive fecal tests, which has made a significant difference in our ability to get our patients their full complement of screening. And we also know that provider time is expensive, whether it is in the endoscopy suite or in the clinic. And we develop processes with our hospital partners to refer patients directly for colonoscopy so that they did not have to make a stop in a GI clinic, which saves the patient time, saves the provider time, and also allows the provider to see a different patient who has a different insurance in their offices. It was also really important that we develop strong community partners to get our patients closure in their ultimate screening, because we know that we as a health center can't be everywhere or do everything. So we partnered with Uber Health, and they have provided transportation for a large number of our patients to get to colonoscopy appointments. And then we also developed relationships with some smaller organizations within the Chicago area that provide accompaniment and support to patients in navigating health systems. So the example is Taller de Jose in Chicago. And we've found that this navigation really does help our patients. This is information that a resident of mine presented at the American College of Gastroenterology conference recently, looking at the success of our navigation program, where we increased our colonoscopy completion rate from 42% to 62.9%. Not quite that 80% that we're looking for, but we're getting better. And we also were able to not statistically significant, but we did decrease the time to colonoscopy for the patients with the navigation program as well. As you can see, we really think about how can we lower barriers to screening at Erie. The work that we did on navigation was tied with work that we did to really have campaigns to help increase our rates of colon cancer screening, and we're really proud of our successes over the last couple of years to increase our rates of screening from 49% to 67% across the board. And this has enabled us to be recognized nationally as a national quality leader in cancer screening, which is a significant achievement that we're very proud of as an organization. So thank you.
Amazing. Thank you so much, Miranda, for sharing your story and all of the incredible work that you've been doing. I have a few questions to kind of kick us off, but if you have questions out there in the audience, just make your way to the microphone and then we'll have some time for discussion. So I have lots of questions, and so many things that you all shared were really, really interesting and thought-provoking. Let me start here. You know, the navigation thing is really interesting, and I think it's clear that navigation really matters, both in like completing the screening process and then into treatment, as we heard yesterday. But I'm also interested in experiences from a health system perspective on like how we talk to patients about an abnormal stool-based test, and then how we train navigators to help patients understand the significance of this and the importance of timely follow-up. So I don't know, Frank, do you want to start, and then maybe Miranda, you can comment on that, and then I see we have lots of audience members with questions too, so I'll move to you here in a minute.
Yes, thank you. This is one that I have a real passion on. In my own organization, when I was going through the data trying to figure out who did the timely test and who didn't. I noticed that whenever a primary care doctor would attach a result for an abnormal stool-based test, send it to their medical assistant and say, this patient had a positive stool test, have them call 412 doctors to schedule a colonoscopy ASAP. They were scheduled. When it was, tell the patient, unfortunately, their stool-based test was positive. It might not be cancer, it could be a hemorrhoid. If they're interested in having a colonoscopy, tell them to call us. None of those patients scheduled the test, so we need to come up with a roundtable with a proven message that we can share with everyone across America of what to say to patients who have abnormal stool-based testing. So, yeah.
Yeah, the script, that's great. I think that's important. Any experiences there, Miranda, anything you've learned from your navigators or what helps patients understand the significance?
Yeah, I think one of the most important things to think about is the fecal testing is really only as good as the follow-up to colonoscopy. And so we really stress that with patients, even at the time of ordering. If this is positive, you are going to have a colonoscopy. That is how we complete the screening. And then when our navigators are talking to patients, it's really, the assumption is that the patient is going to have a colonoscopy, and their job is to figure out how to get that patient to a colonoscopy.
That's great, thank you. Screening as a process, screening is not really a test. Maybe that's some of our messaging to work on together too, is that screening as a process or the continuum to actually complete the screening process. Let me turn here and then we'll go to you, Peter. So first question.
Hi, I'm Dory Lane. I represent the American College of Preventive Medicine. I'm also at Stony Brook University Medical School. And I have a question for Dr. Lieberman. First, I want to compliment you on the work that you're doing in developing a HEDIS measure. And I think, as you pointed out yourself, it's not that simple, to derive, what should it be. And one of the many hats that I wear at Stony Brook is being the program director for our residency in public health and general preventive medicine. And they get involved in doing quality improvement studies, particularly with colorectal cancer screening, and spend a lot of time at the VA. I think you yourself have worked at the VA. And I know in one of their studies that it became clear that a large number of the patients who didn't get the follow-up of the positive stool test, or at least appeared not to get follow-up, were people who were veterans who didn't use the VA as their total source of care, that they actually might have had or did have, follow-up of colonoscopy outside the VA system. So I wonder, when you're working on the HEDIS measure, and who's responsible, or are you selecting a population that gets the care regularly from that provider, so that you're not punishing, let's say, or blaming a group that really doesn't have responsibility for it?
Yeah, that's a terrific question, and I think it's one of the things that will be we hope we'll understand better during the field testing. I mean, you're correct that in the VA system, many patients do get some of their care in the VA, but then they get care outside, and putting that information together is sometimes difficult and challenging, and I suspect the same is true in other settings. I think at the end of the day, what we're hoping is that we'll be able to capture at the primary care level when a test was positive, a non-invasive test, and then when a colonoscopy was performed. The other part of that I alluded to right at the end was, if a colonoscopy is performed but it's not an adequate colonoscopy, what then? And I think that's another issue that we're going to have to wrestle with, and we'll see in the field testing how often that arises.
Great, thanks. Do you want to say something, Frank?
David, I saw in the second paper that Elizabeth Siemens did, they combined claims data along with the EHR data, and the claims data may have underestimated about 8 to 10%. But HEDIS is an insurance measure, so the insurance company should have the claims that would. I'm worried, how am I going to let the insurance company know as a primary care doctor that the patient had a positive stool-based test? That's the one that I haven't been able to figure out. So,
right. That's right. So, measures have to be measurable, and so that's what will be determined, during the field testing period.
Great, thank you, Peter.
Hi, Peter Liang from NYU and the VA. I was wondering, as has been said, it's incredibly important for us to educate our patients that any abnormal stool test or non-invasive test needs to be followed by colonoscopy. But given the time crunch that's often present in primary care appointments, perhaps that doesn't always take place. So I was wondering, from the literature and from your own experiences, how important is it to have that very thorough explanation up front, versus can we do it kind of afterwards where it's already abnormal, given that at the front end it's a hypothetical situation, but at the back end it's a very real situation, but is it too late in that respect, or can it be overcome with more education, patient navigation?
Yeah, I think a lot of times when we're ordering fecal testing at the bedside, it's in the context of a general conversation about the options for colon cancer screening. And so what I usually tell my patients, it's not a long conversation. It's like the options are, you can go for a colonoscopy right away. That is going to take you at least 18 months to schedule, and you'll have to do the prep in advance, et cetera. And for many of my patients, that itself is a barrier. And I say, or the second option is to do a fecal test. And so if that fecal test is positive, you will still need a colonoscopy. And that's really it. That's the conversation that happens. I have 15 minutes with each of my patients. My patients are incredibly medically complex, and so I really don't have more time than that to talk to them about it. And I think setting the stage in that way then allows for more conversation when, in the 5% of the time that the test is positive, to actually go into more detail about what that means. And help patients seek the, understanding for the next steps. I really do think that is the best way to set the stage for them in order to increase the likelihood that they will follow through.
I agree with Miranda also. I mean, I credit Rich Wender. He taught me to say to the patients, I will agree to allow you to be screened with stool-based testing if you promise me that you will do a colonoscopy if the result is positive. So now that works when I'm doing it in person. Whenever you have a mailed bulk campaign, then those ones are a little harder, I think, to convince those patients that you didn't have the conversation. It doesn't take that long to have that conversation with the patients. So.
That's great.
Yeah, I think as we all know, primary care physicians, and many of you are primary care physicians, have a lot on your plate. We have some experts in the room that have worked with artificial intelligence, and artificial intelligence is making its way into our lives in many ways, but one of the ways that I think it could be very effective here is for education. So it is possible to conceive or imagine of an AI tool or a bot that could provide that education in the appropriate language to the patient, and actually be able to have some interchange with the patient so that questions could be addressed. So a pseudo navigator, if you will. But I think that's also a possibility to do what Peter's suggesting here.
Yeah, interesting, very interesting. Pascal, a question?
Hi, Pascal White from Mount Sinai. I was ferociously writing notes because this, Dr. Hart, what you were working on at Erie is something that I'm working on as my inaugural fellowship for the United Hospital Fund, which is a health equity fellowship that I'm concentrating on an East Harlem community-based organization, increasing their colorectal cancer screening rates right now for the past 18 months. And one thing that you had mentioned was the referral pathway. And I think that that's so important to kind of establish a relationship with institutions that surround FQHCs in order to build a better partnership and better communication around the referral process, because you're entrusting us with your patients to take care of them and close that loop from an institutional standpoint. So my question to you is, how did you approach the institutions? What were the successful ways in which you engaged the institutions in order to have that closed loop communication? And what were some of the barriers that your patients kind of went back to you and faced when they went to these institutions for their colonoscopy in order for them to at least get the care that they need?
Yeah, we are really lucky at Erie to have amazing hospital partners with the Northwestern Hospital Network and also the Endeavor Hospital Network in Chicago. And part of that is just ongoing conversations with them about our referral pathways. They donate a lot of their time and their resources to Erie, and we have to show them that we're being very good stewards of that time and resources. And so when we were looking at our referral rates of colonoscopy and they were, questioning how much time and resources they were giving to us, we had the capacity to say, we have a much larger population of patients who need screening for colon cancer, and we're doing it through fecal testing, which can then ensure that we're sending you the patients who are the highest risk patients for this, either because of family history or personal history of polyps or because of a positive fecal test. So I think having that conversation with them and really showing that we are being good stewards of their resources that they were giving us was the most important thing to help them have buy-in for having these expedited referral pathways. And then honestly, it's really, having that person who has a personal connection with a person in the hospital resource to say, this patient had a positive test, let's get them in for colonoscopy. And those personal relationships have been fundamental to how we work as an organization. Regarding, what was the second part? I can't recall the second part of your question, I'm sorry. Oh, patients, yeah. This is actually something that we're dealing with right now. For the expedited colonoscopy process, one of our hospital systems has requested that we fill out an additional form beyond the referral to say what the reason is that we're sending them for colonoscopy and whether or not, if they're on high-risk medications, they can be held. And so that has actually created a significant delay for some of our patients, especially those who don't speak English or Spanish, who have a hard time navigating the referral system in general. And so it's things like if they really do need that additional information, building that into our electronic health record tools. So, embedding that information within the order itself so that they have everything that they need in order to schedule the patient right away. And I think the phone systems, I alluded to this, it actually is a really significant barrier. And so having somebody in the health center who can sit with a patient who doesn't speak English or Spanish and actually sit with them and help them schedule that appointment is a huge benefit to our patients. And we definitely see that patients who don't speak English or Spanish have much lower rates of completion of all of our referrals, but having that additional person within the health center, so actually sitting with the patient, we have a social drivers of health team that helps those patients, particularly those who don't speak English or Spanish, navigate those phone trees.
Incredible, thank you. Next question.
Asma Shaukat from NYU and the VA. Thank you so much for an amazing panel. I think this is where our focus should be for the next many years. I have two quick questions, one for Dr. Hart. Navigation is absolutely wonderful, but it's also really expensive, and it's, sustainability is an issue, and also it's delivered very differently there's no way to standardize it. So my question was, have you thought about any digital navigation tools or, other ways, SMS or other navigation tools that you could adopt for long-term sustainability? And my question for Dr. Lieberman and Colangelo was, it's clear that follow-up of abnormal fit, has multiple stakeholders and partners. So it's not the primary care, it's also the patient, the GI practice. So how do you think, or who should be responsible primarily for it, or how should that responsibility be shared, particularly when GI is not part of the primary care practice, and these FQHCs or other systems have to rely on sending them out. So what is the responsibility of the GI, or how should they be? What's the best practice to hold them accountable? Thank you.
Great, good question. Do you want to start, Dr. Hart?
Sure. Yes, so we definitely use digital systems as well as phone calls to reach patients and in-person navigation. The digital systems that we use are through a text messaging system, which is called Artera, which is a bi-directional text messaging system. So we send out one, mass text message, your colonoscopy was ordered a month ago, are you having trouble screening? And then patients respond, so we can prioritize outreach to those who actually respond to us that yes, they're having difficulty navigating that. And also through our electronic health record, through the MyChart patient communication system. And some of the difference between, whether they we're reaching out through MyChart or whether we're doing phone outreaches based on patient preference. But we do utilize those resources as well.
Great. Next, on to the next question about responsibility. Good question. That's a
I
great
mean, I
question.
hope that it would be a joint, you know, the organizations that had most success said it was a joint. I came 10 years ago when I was Premier Medical Associates and we were independent and had 35 primary care docs and 2 full-time GIs and had 90% of our patients done within 30 days. I was in heaven. It was fabulous. Now that I'm part of a big system, I actually had the head of GI say to me, the reason why the 90-day follow-up rates are so bad is because you primary care doctors are ordering too many stool-based tests. Did I see the former head of the GI division? Did I say that or not? Yeah. So so.
Thanks for clarifying. Do you have any thoughts, Dr. Lieberman?
So in terms of responsibility, screening occurs at the primary care level. So I think the initial screening effort, is the responsibility of primary care physicians. I think most of you who are primary care physicians here would agree with it. My view of the responsibility of the GI side of this is that we, and I'm a gastroenterologist, that we should be prioritizing these cases. So I think that our effort really should be focused on setting aside time and space so that these higher risk individuals can be prioritized. That was my TSA kind of approach to thinking about this. But clearly, these are the higher risk individuals, and they should be prioritized in practices. So in terms of responsibility, I think that should be the responsibility of every GI practice, is to allocate time for these cases.
Mm-hmm. Thank you. Dr. Hatz.
Well, I got a great follow-up on that. I represent the Community Health Center Committee since it began, and the number one reason that we don't screen as much as they give is we don't have an open door to gastroenterology. Biggest reason for our uninsured and other folks. We did a presentation for the work we're doing in Georgia where we got a 90% show rate through our large community health center system working with Lynn Durham and a CDC-funded program. And we outlined and presented to the American Society of Gastroenterology, there's actually 9 doors that have to be open. We have a navigation system we can get them through if they're all open. The problem is the biggest, hardest door is the GI office. We were able to present for the Georgia Gastroenterologic and Endoscopic Society. We brought over Brian Green from South Carolina, and he showed what they did, and they opened the doors, and they had like 50 practices doing that. I had 5 GI groups come up and say, hey, we'd like to partner with the community health centers in Georgia. The problem is, in the last 2 years, half of those groups have been bought up by United Digestive, a for-profit. Now, at the round table, the King Arthur is the gastroenterologist. Excalibur is your endoscope, because you really cure cancer. So I kiss their butts and I show them how great they are, and they love that. But the problem is that they no longer are the key decision maker. The round table has equal say, but when you bring in a corporate profit-driven partner and you're owned by a practice that doesn't share the values of King Arthur, I think that's an issue we need to take on. Why shouldn't we be talking to United Digestive and some of these other for-profit things and say, can't you have part of what you do set aside of 2% or 3% so you open the door? Have we thought about doing that from the roundtable perspective?
It's a great question. And we're all looking at each other. I think it's a great question. Would you like to talk after? Let's talk.
Can I segue?
I'm more than willing to talk to him, but...
I think, I guess I'll say something, answer maybe on behalf of my other role at ACS. I think it's actually a really good idea, Jim, of course. You have really good ideas. But it maybe is something that we can do from the American Cancer Society within the roundtable leadership to have a conversation representing a large organization, really show the data and show the impact, and then that we're not asking for the moon, we're just asking for something very practical and reasonable.
And as I talked with Dr. Lieberman as we were working out this morning, we're both 75. Our goal is to get to 80% by the time we're both 80 years old.
I love that. We've got 5 years. I love it. Rich and Steve, you're gonna. Oh, I hope
Actually,
you're
I have
first.
a great segue. So
Yeah.
thanks, Jim. You set me up perfectly. And it kind of goes against to Dr. Lieberman because, you know, we've all been in this sphere for quite some time, and we all know patient navigation work. I mean, I've had a safety net patient navigation program for 13 years. Yes, South Carolina goes to other states. I always thought, and we always think of navigation in the sense of what can it do to help the patient. And someone that I hired recently, Dr. Makaroff, made me realize, because he's reviewing the literature, right? So stuff we've read a long time ago, and Dr. Coronado, we're having these discussions, AI, education, all that fun stuff. And something that he said that really turned on the light. Your data that you presented on integrated healthcare system, and we're always like, yeah, we all want to be Kaiser, right? We wish we could do that. And then I wondered, well, how is it that in South Carolina, or you at your navigation program, you reach 78% compliance to stool-based testing to colonoscopy? And all of a sudden, the light shone. And it's because our navigators are not just working with the patient, they're working with the GI practice. So our navigators are talking with the GI practice. When they send a referral, they follow up with the clinic's referral system, and then they are creating this relationship that becomes almost like an integrated care, right? Where when a referral from CCPN gets to the GI's practice, they know that patient has been done a thorough risk assessment and they really need a colonoscopy above all else, or they have a FIT positive or a Cologuard positive that needs to be followed up to colonoscopy. And I really agree with you, Jim. I think that's maybe where we need to, how can we bring a sphere where we're taking out the silos or working with the silos to bring them in together to work better through our navigators and help our navigators to have the tools to get there. So yes, if the roundtable can make that a goal, I think it would be something that I think we can work towards, because I think that's the key portion. The patient needs help. The providers that we refer them to them needs to know that they've been prepped. They understand how to be prepped. They understand how to do a clear liquid diet. They understand the importance. How can we get them to not wait 6 months, even if they have no insurance? So I think that, I don't know if there's studies on that, Dr. Lieberman. I'd love to hear it, because I know the folks in South Carolina would love to hear from you again. But I think that's a key point to the discussion, is how do we integrate the care in non-integrated system?
Definitely an issue. Yeah, thank you. Thank you for your comments. Question or more comments here?
It's a question for Dr. Hart. Maybe if it's unanswerable, just tell me it's unanswerable, but maybe you can at least confirm that it's a concern. I've been impressed in our many partnerships with FQHCs that some of them are financially struggling despite grants and despite enhanced risk-based payment. And when I listen to you talk and other very successful FQHCs in quality, it's what they don't talk about is what does it take to be financially sound enough to be able to invest in these programs. Just the fact that you guys are still on an every 15-minute schedule, whereas most of primary care outside of FQHCs has moved to at least every 20. So any thoughts or just general observations about the financial stresses that FQHCs are facing?
Yes, they're real. They are many, between concerns regarding Medicaid and our patients' ability to continue to be insured and grant funding, et cetera. I think Erie our philosophy has always been that it has to be a team taking care of patients. And when we think about things like productivity and even doctor salaries or provider salaries, and then provider mix, those are some of the things that go into our ability to then support our population health team and the additional work that they do to help support patients and providers. And we actually have that conversation with providers as we're recruiting and onboarding. We have a team approach to healthcare. That team costs money. Our salaries are not as high as what you would get even at some other FQHCs that don't prioritize this in the same way in the area. And then thinking of the other piece of it is the payer mix and the ability. So we're really lucky at Erie also that we have a robust pediatric and obstetrical practice, which is a very heavily insured patient population. which the additional revenue from that can then support some of the care that we provide for some of our more complex adult patients who tend to have a higher uninsurance rate. So it's really many puzzle pieces fit together that allow us to support the work of that team. But yeah.
Thank you. Let me do a quick time check, Caitlin. Do we have one more question? Okay, we have time for one more question, and then let's continue the conversation in the break and throughout the day.
Thanks. Chris Moore, Veterans Health Administration, was struck by the thoughtful link between navigation and career ladder. I was wondering if Dr. Hart, if you could talk about the lowest rung of that ladder, and if there's time, everyone on the panel, what role do non-clinical navigators, community health worker types play in this? Thanks.
Yeah, all of our community health workers or navigators are non-clinical. The lowest rung on that ladder is really just looking at the population health metrics, and they're not just working on colorectal cancer screening, they're also, getting patients back in for diabetes care and pediatric vaccinations, things like that too. But really it's just from a colorectal cancer screening, placing an order, and we have standing orders for them to do this for any patients who are at average risk for colon cancer and due for their fecal test, placing that order in the computer so that takes one step off of the provider's plate, so that we can focus on other things in the visit, like educating patients on why they need to complete the test. So they are really just, all of them have high school diplomas. I think that having a college degree is not required, but we have a fairly easy to run report that is given to them, and then they follow those steps.
Great. Thank you. Let's say thank you again to our panelists. Thank you for the incredible talks and the work that you're doing.